for our annual Ben Alman research rounds at the University of Toronto Department of Surgery, and also welcome all of you who are online. It's really wonderful to see a good turnout for what I think is going to be a very interesting, exciting talk by our visiting professor, Andrew Hung. But before we begin the formal proceedings, I'd like to also take a moment to acknowledge the fact that the land on which the University of Toronto operates and the land on which we're meeting here today has for thousands of years been the traditional homeland to many different Indigenous peoples, and it continues to be the home of many Indigenous peoples across Turtle Island. I'd also like to recognize the historical injustices and inequities that our Indigenous colleagues and family have faced, and to, on your behalf, hope and vow that we will do better in our relationship with them and also with the land of which we are all stewards. So next up, we have a real treat, somebody who we don't hear from very often, who's going to tell us a little bit about Ben Alman. Ben Alman, who is here with us, not just of historical interest, but of present interest. And that person is Sivan Hopian, one of the orthopedic surgeon scientists at SickKids. Sivan, I know you're here somewhere. Oh, yes, there you are. Come on up.
Good morning. It's a pleasure to say a few words about Ben. So Ben is from Philadelphia originally, where he initially studied engineering. His orthopedic training was at Tufts, where he went back after a fellowship in this building in pediatric orthopedics for a few years to begin his career. He was recruited here, where he spent many years ascending in pediatric orthopedics and in the department. He was chair of our division at SickKids, chair of the department orthopedics at the department level at the university, and vice chair of research. And not only did Ben promote research and science at the program level, he did so for individuals, went really out of his way to spend time with individuals to promote their careers, especially in academia. And one of the legacies of that is that in orthopedics, at least, the number of hospitals that have research labs has actually increased or expanded during his time. So the characteristics of Ben, which actually contributed to that expansion, are that he's really his love of science, his open-mindedness, his enthusiasm, which is infectious. Sorry, Ben, I'm having trouble reading your writing. His unfailingly positive and optimistic approach to science in general, but as I say, to individuals, trainees in his lab, people that he mentored, people that he came across, and really just showed people a tremendous amount of generosity and grace. That's the word for it. One is always better off after an interaction with Ben than before. So with that, thank you, Ben, and I look forward to your talk.
Okay. So good morning, everyone, and a welcome to our kind of opening academic event following our Christmas and New Year's break. I think most people know me. I'm Michael Failings. I'm the vice chair of research, and I have the pleasure of actually stepping into Ben Alman's shoes, and it's kind of a wonderful honor to kind of anticipate, where is science going? And we live in the world now of artificial intelligence, and kind of with that theme, it's a pleasure for me to introduce Dr. Andrew Hung, who's an associate professor at Cedars-Sinai in Los Angeles. He also holds a position in computational biomedicine, and administratively is vice chair for academic development at Cedars-Sinai. When a group of us were trying to brainstorm, who is kind of leading the field in artificial intelligence, robotics, and surgery, there's one person's name who came up repetitively, and I was very pleased that when I first contacted Dr. Hung, the answer was yes right away. So that was wonderful. So we have a few kind of bullet points here in terms of Dr. Hung's background. So undergraduate training at Yale, and then went to Cornell, and then spent much of his training in urology and fellowship, and then subsequently initial faculty time at USC, and then over the past couple of years has made the transition over to Cedars-Sinai, which really I think is kind of an interesting ascendancy, academically in terms of impact. So Dr. Hung currently has a number of NIH R01 grants related to the interface between robotics, surgery, evaluating outcomes, use of artificial intelligence, and has authored over 200 papers. And he's really been a leader in the applications of robotics and AI to the assessment of kind of advanced surgical approaches, as well as surgical simulation. So we really felt, Andrew, that you were kind of ideally suited to give this talk, and we've got actually a very good turnout. We've got a very good turnout this morning on a wintry morning, and a lot of people who are online. So Andrew, with that introduction, would welcome you to please deliver your lecture on automation of robotic skills assessment with artificial intelligence.
Good morning, everybody. Thank you for such a warm welcome. It is a little chillier here than it is in Los Angeles, but at least we're not surrounded by fires and smoke. So I appreciate really the opportunity to be here, and it's truly a humbling experience to be standing in front of all of you in this very storied program here in Toronto. So these are my disclosures, and I am funded by the National Cancer Institute in the States, and these are our active grants. So today I'd like to cover a number of topics. We'll breeze through the first two. What is AI? I think most folks in here know what that is. But what is surgical AI? And I'll share with you our decades now long experience with using AI to assess the quality of surgery, and our more contemporary work looking at how we can deliver live surgical feedback in the most opportune way. We had a wonderful dinner last night where we were talking about how can we make training more impactful, and I think a lot of that will be there. So I'd like to share a few thoughts about where we're headed in that direction. And then finally, some take-home points. So what is AI? It is the ability for machines to independently replicate many of the intellectual processes that we typically see in human cognition. And we've all heard of machine learning and deep learning. So what are they? Well, machine learning is a subset of AI where these algorithms can parse through data, but most importantly, learn from it, and then make informed decisions. And deep learning is yet a subset of machine learning, where really these algorithms are inspired by the human brain, where you have these interconnected neurons that optimally make these decisions or these insights in a greater scale. Okay, so what is surgical AI? Well, it's more than appropriate then to ask ChatGPT, what is surgical AI? It refers to the use of AI in surgical procedures to assist and enhance surgeon performance. So note that it's assist and enhance, but not replace, at least for now. And nowadays there are visual language models in place. And so this is also asking GPT, well, what does that look like? Well, you can use your own imagination of, this is AI using its imagination of what that actually is. Taking in data, maybe pre-surgery, data that's during surgery, and data after surgery to really guide that experience of treating our patients in the surgical theater. Okay, so in the last 10 plus years, we have done some work, and my focus, it all started with my own frustrations of learning to become a surgeon, that I felt that that process was rather a haphazard process. And it wasn't because I wasn't at a fantastic training institution, but more because that was just the traditional model of becoming a surgeon. So for the last 10 years, we have tried to do a 360 evaluation of how surgeons perform in the operating room. And so we've approached this in 3 different ways. This is just a nod to the last 10 years of research and being really fortunate to have $10 million of active funding from the NIH to do this work. And it's truly a humbling experience getting to pursue an area of research with support from the NIH and really being enabling us to do this work. But I'll start with kinematics, and I'll explain what that is. Kinematics, there's technical skills, and there's surgical gestures. So first, kinematics. So this project we started perhaps 2016 or so, almost a decade ago, and it was a partnership with industry. It was a partnership with Intuitive Surgical, where we placed these black boxes. They were literally black at the time. Then they became gray, and then now they're white. But at the time, they were black boxes, where we were recording surgical video during live robotic prostatectomies, and synchronized with that, where we were also pulling systems data from the robot. So similar to a black box on a plane, we were collecting how fast the surgeons were moving with their hands, where they were in 3D space. That's the instrument kinematics, but also events such as energy use and camera movement. And it's from this data that we distilled what we coined as automated performance metrics. These were automatically collected, and they were performance metrics about the surgeon. This was our first paper featured here on the Journal of Urology. And this is an illustrative example of what we were looking at. So these are 2 different surgeons performing the exact same task within the prostatectomy. It's one of the initial tasks. The red is the tip of the right-hand instrument, the green is the tip of the left-hand instrument, and the black is the tip of the endoscope. And so these are 2 surgeons doing the exact same task, but looking very different. And well, what do you make of it? You know, objectively or even subjectively, you could say, well, one looks kind of a mess and the other one looks pretty focused and concentrated. This is data that we're collecting at 30 hertz. So 30 times per second, we are refreshed with new data. Now, what do you do with all this information? That was our earliest question, was how do you process this length of, or this volume of information, parse out what's important and what's not? And just because you can collect that data doesn't mean it means something clinically. So this was our first foray into using machine learning with data from the operating room to make sense of that data. So what we did was we took 70 odd prostatectomies, robotic prostatectomies, and for each case, we collected these metrics. These are the metrics of velocity, acceleration, angulation, or movements of the wrists of the instruments as they're suturing, for example. And for each set of these metrics, we tagged it with a clinical label. Now, in machine learning, this label could be anything. But early in our experience, we didn't have much long-term data. So what we had was hospital length of stay after prostatectomy. Most patients stayed in the hospital for 1 or 2 days, and occasionally they stayed for more than 2 days. And so we tasked a machine learning model to predict how long the patients were going to stay in the hospital for using just these automated performance metrics. So with the trained model now, using these 70-some initial cases, we have a brand new case. We just finished it in the operating room, and we plug it into this trained model, and we predicted how long that patient was going to stay in the hospital for. And to our surprise, we found that this model was correct about 80% of the time. This is using only information from the time of surgery. And really, this encouraged us to to dive deeper and learn more and see what else we could do with machine learning. This is more than anything just to show off that in the course of 3 years, the topic of these automated performance metrics really garnered a lot of attention, particularly in urology, and it was featured in 4 of the 4 covers of the Journal of Urology. But while I can brag about this, there was a very big pitfall to kinematic data. Kinematic data tells you what the instruments are doing, but guess what? In surgery, what matters is what happens to the tissue. It's that engagement of the surgeon to tissue that really matters. And so on a hunch, we're like, well, maybe technical skills, which is again, technical skills is the assessment of how the surgeon engages with the tissue, maybe that matters to some degree as well. So this came along a subsequent study where we tried to up the game in many different ways. One was we're going to look at an outcome that people may care about more in the long term. And then secondly, we wanted actually to predict when patients were going to achieve that outcome. So for the prostatectomy, I imagine I'm in a room of less urologists than usual. But for any given outcome, there are going to be patient factors and there are going to be surgeon factors that contribute to that outcome. And depending on what that outcome may be, the weight may be different. Okay, so for the prostatectomy, we've been doing this for many decades now. But one of the main functional recoveries is urinary continence control. Historically, patients would take months, if not years, to recover that function. And we, in our initial data series, we saw that the rates of recovery ranged anywhere from 5 days to 450 days if they recover function at all. So certainly there is room for improvement there. And we knew that, again, there's patient factors and surgeon factors that may contribute to this outcome. So for the surgeon factors, we thought, hey, well, let's use these automated performance metrics. We have the data. Why don't we use it? But in addition to that, let's bring in technical skills. Now, these are examples of technical skills for suturing, but you can imagine that there's a parallel set of metrics you can use for tissue dissection as an example. So for suturing, there's how you hold the needle, there's how that needle enters the tissue, how you drive that needle into the tissue with a nice rotation of your wrist, how the stitches are placed, how well you oppose the loose ends of tissue, and then you're not tying. And for us in the prostatectomy, this is during the vesical urethral anastomosis. That's the reconstructive part of the operation once the prostate has been removed. So these were our outcomes. And again, this is using the data we have in front of us to predict when patients were going to recover urinary control after prostatectomy. If we use the automated performance metrics, we had an AUC. This is a performance metric of how well the model can do to predict this particular outcome. No matter what we did, we were hitting a ceiling of the 60s, and that's really not wonderful. But adding the technical skills alone, the AUC went up to the 70s, again, to predict when patients were going to recover urinary control. And if you added everything we had in front of us, the characteristics about the patient, for example, his age, these automated performance metrics, and the technical skills, we hit the 80s, and that was very encouraging. Now, machine learning models can do 2 primary tasks. First is a prediction. That's what I just shared with you here. In our case, predicting when these men after prostate surgery were going to recover urine control and not have to wear a diaper anymore. But secondly, it can also do what we call feature rank, which is looking at all the features or all the data points available to this model, which were actually the most helpful in correctly predicting that outcome. Of the top 20-some features, the only patient metric that was ranked up there was age of the patient, and that's consistent with the data or the literature that we have already. And interestingly enough, 3 of the top 5 were these technical skills metrics. They were not the kinematic data. And so because of this one study, it's really informed maybe the last 8 years of work. And this naturally leads into our first R1 grant, which is to automate the assessment of suturing using deep learning models. So this is our first of 3 active grants. And it's a multi-institutional study. We talked last night about having to have collaboratives to do meaningful work. So each one of our grants have been collaborative studies. This one is with Cedars, MD Anderson, Houston Methodist, University of Rochester, and City of Hope. So this is data coming from all of these different sites, graciously sent by our partners. And then the AI component is done at Caltech with Anima Anand Kumar. So in JAMA Surgery, this is really before this paper or before the project started, we set out what our vision was for this project. So we wanted to take surgical video of folks suturing. We wanted to use those videos visually to train a deep learning model to provide a report card of suturing skills. And notice how detailed these metrics are. If it's needle handling, it's how many times the surgeons pass the needle back and forth until they have it in its opportune position. For needle driving, it's how smooth that action is of pushing that needle into the tissue. For suturing placement, it's how aware is the surgeon of that suture, that dangly thing, that can get in the way and get caught in the instruments, and so forth. And again, this harks to my origins of my research, was that passion for teaching and wanting to make sure that when these models, which are otherwise opaque in many ways, are providing an assessment that is granular and that there's no guesswork of what is done correctly or not. But this is only the first step. The second step is, once you have that report card or profile about a surgeon, is that we're going to train a separate model to predict patient-reported outcomes, because ultimately it doesn't matter what this report card says. What matters is what happens to the patient. So this is from 2 years ago now. We published 3 papers in the Nature portfolio journals on the findings from our work so far. So first of all, we created a surgical AI system for skills assessment, amongst many other tasks that this model can do. I'll go into a little bit more detail in a second. Our second paper is about fairness. Now, if we're going to do an assessment on surgeons, we better get it correctly, right? Because if you can imagine down the line, whether this is self-education, if this is for credentialing or other high-stakes things, that those are potential applications. We want to make sure that the models perform fairly. And then also, surgeons are not going to just get a, hey, you didn't do a great job today. We have to have some explainability. We have to have some paper trail available. Okay, so this is the first of those 3 papers, where we trained a vision transformer, that's the type of model, to decode surgeon activity, what they're doing and how well they're doing from just surgical videos. We were proud to have this featured on the cover of Nature Biomedical Engineering. And busy slide here, but there's one important point. At the very top, that's your surgical video. And in 2 different ways, we're interpreting those videos. The first is, what are the changes of pixels over time? Because video is simply images that change over a length of time. And so that's the first approach. The second is, we do these optical flow maps, which overlays onto these images what's moving, at what direction, and at what magnitude. And from this information, we distill it down to a single verdict of, for each of those sub-skills within suturing, as an example, was that a good example or was that a bad example of suturing? Okay, secondly, when we trained our models, we were able to get its performance up into the 80s. These are the AUCs in the 80s, compared to ground truth evaluations done by human raters. So we're patting ourselves on the back and saying, job well done. However, when we deployed the models in the real world, we found that the models were performing unevenly for different cohorts of surgeons. Here, as an example, our less experienced surgeons, the models performed a bit more accurately than our more experienced surgeons. In a different environment, in our training lab, where we had medical students suturing and we were recording their suturing, we found that the models were behaving more consistently and accurately for female medical students than our male medical students. And we couldn't quite explain why. But there are a few strategies where you can use to mitigate this bias. And in doing so, you can improve the model's performance. And this leads into the third paper, which we'll come back to, this bias in a second. But if you ask a human rater, they have to watch a string of videos on suturing, and let's say there's 1,200 frames. Well, that trained human annotator or evaluator doesn't have to look at the entire sequence of 1,200 frames to make an assessment of, let's say, needle handling. Again, that's when the surgeon is passing that needle back and forth until it's in a good angle and position to drive the needle into the tissue. That human rater only has to look at the sequences of that video where there's actual passing of that needle back and forth. So here in the yellow, you see that's where the needle handling is occurring. But when we asked our AI model, hey, where are you looking to make your assessments? In some ways, it was looking in the same spots as our human rater, but in others, it was looking somewhere in the middle where there's absolutely no needle handling occurring. So if we retrain the model to look where the human evaluators were looking, the model performed better. And interesting enough, that bias that I just showed you in the last paper, it actually got better. So these are very early works into recognizing that there is what we call algorithmic bias. And secondly, this is an example of trying to explain, what's going on and what's going wrong in these assessments. Okay, so we've talked about kinematic data, we've talked about technical skills, and I'll share with you our more contemporary work with surgical gestures. This leads into our second active grant at the moment, and it's using a deep learning model to assess the nerve spare step of the prostatectomy. So the robotic prostatectomy is a procedure we have been doing for decades. The nerve spare step is that critical step of preserving the nerve's neurovascular bundle to preserve erectile function for sexual intercourse. The outcome of this procedure is that approximately 20% to 50% of patients do not recover function. So again, this is something where we could do better on. And again, this is a multi-institutional study with data coming from ourselves, Cornell, Stanford, MSK, and City of Hope. So this is our first paper in Nature Digital Medicine explaining this concept of surgical gestures, and I'll explain. So in surgery is really made up of many, many moment-to-moment maneuvers. These are motions that one does to complete the entire operation. So as an example, this nerve spare step of the prostatectomy on average is about 200 to 400 gestures, individual gestures. And there's blunt dissection, there's sharp dissection, there are combination gestures that can be done. So if you're not a urologist, this hopefully resonates with you, because these are the, whether it's suturing or tissue dissection, that should be the bedrock. Those are the basic skills of any surgeon, regardless of field or procedure. Okay, so here are some examples. So for blunt dissection gestures, a spread of your scissors, that counts as one gesture. A peel push, where you're pushing on tissue to open up the natural tissue planes, that's yet another gesture. And this is a hook. For sharp dissection, this is a cold cut without energy. This is an energy cut or hot cut with energy. And from the prior slide, if you saw the hook, now this is burning or activating energy as you pull towards to open up that tissue. And then there are combination gestures where these are just simply movements that are a bit more complex, but they're predictable, that we consider as a unit. So this is to pedicleize, this is two-hand spread, and this is once you have a little pedicle of tissue that you can coagulate the two ends and then cut in between. So let's put this into motion. This is, come back one slide. So So this is surgery happening in real time. You have a cold cut, then you have a retraction move by the left hand. This is a peel, a repetitive peel motion, and then here is a hot cut. So now you get the sense that you could take a sequence of surgical video and decode it into this sequence of gestures similar to the genomic code, and where you have something like spread, cut, burn. Okay, so back to the prostatectomy. There's some automation here that I'm not going to love, but this is the computer taking its own mind. But going back to the prostatectomy, these are the first 100 gestures for folks undergoing that nerve spare step. Okay, so you see here 22 rows. These are 22 patients. Sorry, there's some automation of time here. Okay, so these are 22 rows. These represent 22 patients undergoing the nerve spare step of the prostatectomy. And each cell is a different gesture, okay? What's common about these 22 patients is that while they had sexual function before surgery, 1 year later, they do not recover function. And in contrast, these are 18 additional rows representing 18 additional patients undergoing the same operation. And these are folks who at 1 year after surgery do recover function. So if you take traditional statistical means of trying to predict who's going to recover function and who's not, we can't reliably make that prediction. But if you plug these sequences into these sequential models, these are a particular type of machine learning models that recognize or have the memory of one gesture to the next, to the next, to the next. We can now predict with an 80% accuracy whether or not these patients will recover function 1 year after surgery. For us, this is a big deal because for all the decades that we've been doing this operation, we've never been able to predict reliably when these patients will recover function. You ask someone like Vip Patel in Florida, who's done almost 20,000 prostatectomies, can you reliably predict who of his patients will recover function? And he'll tell you, in many cases, yes, but in some cases, many cases, no, all right? And so this has brought out an opportunity for us to learn more about this particular procedure that we've been done for so long, but without any real-time feedback. Okay, so it's not good enough to just be able to predict an outcome because what's done is done, and that's what's going to happen to that patient. So the last few slides, that's our state of the art to some ways. But what we would love to do, this is aspirational, so I want to be clear, this is not work that we have been able to achieve yet. But what we would love to do is in a given sequence for a given individual, be able to identify, again, this is a little automation here. We want to be able to identify what are the sequences within the greater sequence that is protective for that patient. And in contrast, in a different patient who did not have a good outcome 1 year after surgery, we want to identify what were the groups of gestures that were putting that patient's risk or increasing their risk of not having a good outcome. So gestures we introduced about 3 years ago. This is ongoing work. What we realized was that we need to provide a bit more context. So in that original paper for gestures, we were able to identify sequences that the model was bringing up and saying, hey, this is an area of good behavior, or this is an area of bad behavior. But individually, from a case-to-case basis, we could not really understand what was being done so well in those few gestures that was protective, or what was done so terribly that it would have been deterministic for that outcome. And so in our last year, this is unpublished data now, we've been trying to provide more context to those gestures. So imagine reading a book with just letters and no spaces or punctuation marks. That's what essentially our generation 1 of gesture sequencing looked like. Generation 2, as we call it, provides functional units. So these gestures collectively form words that have a unique meaning to them. For example, they're trying to release the neurovascular bundle, or they're trying to open that posterior plane between the prostate and the rectum as examples. And there's also something else that we can provide, which is anatomic location. Are these gestures near the base of the prostate? Are they near the apex? Are they anterior, posterior, and so forth? And so this is the state of the art, really, of our work. If you take just the clinical features about the patient, again, this is to predict that one-year outcome. Certainly, those patient characteristics make a difference. If you add just the gestures, that Gen 1 gestures, that bumps up the performance a bit. If you add the gestures plus the clinical information, that increases it up, to the mid 70s. And then the Gen 2 part is when you add the functional units and the anatomic location. This is where our performance keeps going up. So in the ideal world, we know everything about the patient, we know everything about the surgeon, and we can almost come to a near certainty of what that outcome may be, no matter how far into the future it is. Okay, I'm going to switch gears. This is my final topic. This is looking at feedback or surgical feedback. For the last 10 years, we have looked at making assessments. And the final piece to all this, we have not perfected our assessments of the surgeon. There's so much more to be done there. But we thought it would be time that even if we had the perfect assessment of how a surgeon is operating, we have to figure out how we're going to deliver the good news and the bad news, right? Surgeons are, particularly our residents, can be delicate in that period of time when they're learning their skills, and any form of feedback is helpful, but sometimes it can be devastating. This is our most recent grant. This was funded just a few months ago. Again, it's a multi-institutional study where we hope to assess, optimize, and deliver surgical feedback using some AI. This is the preliminary work for this grant. We published this a year ago in JAMA Network Open, where we looked at 30 teaching robotic cases. And from those cases, we transcribed almost 4,000 lines of surgical feedback. Well, you would ask, well, what is an instance of feedback? It has a trigger. It has the feedback itself from the trainer. So this is when a trainee is on the console actually doing the operation with a trainer not whispering in their ear, maybe yelling in his or her ears. And there's something that comes as a result of that feedback, hopefully. Okay, in greater detail, what is that trigger? The trigger could be that the trainee didn't do something they were supposed to do. They did something incorrectly, or maybe they were, just asking a question. The feedback could be about anatomy. It could be about the procedure. What do you do next? It could be about technical skills. Hey, turn that wrist as you drive that needle into the tissue, please. Those are the core feedback components, but there's the bells and whistles. Was there praise laced with the feedback? Was there criticism laced with the feedback? Was there a visual aid that was added on top of what usually is verbal feedback? And then what happens afterwards? In the ideal world, the trainee will change their behavior. That's perhaps a sign of impactful feedback. Or at minimum, did they at least acknowledge what they heard? And then I'll come to the other ones in a little bit. So what is the takeaway of this kind of work? Well, we found that in certain instances, when you deliver, let's say, anatomic feedback, and if you add just a sprinkle of praise to it, you've increased the chances that the trainee is going to change their behavior or at least react to it. This is our early work. What we're trying to, this is observational. We want to see in a wide swath of teaching opportunities what's impactful and what's not. So while this was done with 30 cases, our funded work in the next 5 years, we're going to collect data from 5 different hospitals, 500 cases, and approximately 65,000 lines of feedback. So analyzing these almost 4,000 lines of feedback took about half a year for my medical student to do at the time. And certainly with 65,000 lines of feedback, it would take her entire training career to do that. And so we've created now a pipeline to analyze all these lines of feedback so that in the ideal sense, any hospital, any teaching institution could submit both the audio and the video of their teaching cases, and we can provide some feedback and analysis. This is a paper that just came out 2 weeks ago, looking at using both human and human AI collaboration to better understand live surgical feedback. So it stems from the work I just shared with you. And this is the same outline, that there's going to be a trigger to the feedback. There's going to be the feedback itself. There's going to be the trainee response. And the part that I didn't talk about too much on the prior project was the trainer's ultimate reaction. Did they ultimately approve or disapprove of the trainee's change in behavior, or did they take over finally? That's every trainee's worst nightmare, is that their robot is taken over by the trainer for various reasons. Okay, so in this particular paper, what we did was we had the audio, we had the video from these teaching cases, and the first step was actually an unsupervised classification. So taking all the transcripts that were there, we just asked the model, what do you see as similarities? Put them into the same category or same bucket. These are all unlabeled buckets. And so the model then sorted, these 4,000 lines of feedback into its individual buckets. We actually asked GPT then to look in each bucket and look at the language that was utilized and gave them titles. And these are the titles that you see done by GPT. But the human element is that we asked the humans to look under each bucket and determine, hey, what actually happened when the feedback from that particular bucket was delivered? What happens, in each situation? And as an example, you see here that things that were done in, let's say, the bleeding bucket, okay, things that got put into the same bucket, then got labeled by GPT as handling bleeding, the vast majority of the time, it changed behavior. In very rare occasions, did the trainee only respond by just saying, okay, yes, right? So that makes sense. And this is an example of, these are the word clouds, these are the words that are coming out. Again, going back to that bucket about controlling or addressing bleeding, these are the words that are being recognized by the models. These are the actual transcripts, make sure that doesn't bleed, buzz that, right? Be careful, the vessel, buzz that, come on. So this is a different representation of the same data. Right. So again, that handling bleeding example, every instance of feedback that had to do with that, very, very likely that the trainee was going to change their behavior, but very unlikely they were simply going to verbally acknowledge that feedback. And as just a sanity check, we call sanity checks, things that are otherwise pretty obvious. We want to make sure those things get fitted in the right buckets. If the trainer asked a question, that's not going to lead to a trainee changing their behavior. The trainee is going to answer that question. So, in our analyses, we just wanted to make sure that these sorts of things all panned out. Okay, so my take-home points. As you've seen, in our last 10 years, we've looked at using AI to assess the quality of surgery. There are many other ways that surgery can be assessed, but we shared with you methods through kinematics or the motion tracking, the technical skills that can either be done by human raters or automated, which is some of the work that we're doing now, or surgical gestures, which is building that alphabet to a surgical procedure. But ultimately, if you've seen a common thread, that's been that for any one of these things, we've always grounded it with how the patient does, because ultimately that is the ultimate surgeon performance metric. And finally, shared some work in how we are optimizing the surgical feedback component that will complete the loop. If we know what's wrong and we can deliver it impactfully, that's what's going to allow us to change behavior and change our outcomes. This is a recent team meal. We like doing family meals like restaurants do before or after close. because it, really builds camaraderie and mentorship is a big deal in our group. And thank you again for having me here. It's really an honor and privilege. Thanks.
Well, fantastic, fantastic talk, Dr. Hung, and it's really kind of remarkable to see, the use of, artificial intelligence approaches to track, the performance of surgery, and very elegant work. I think we have time for questions if that works, and then just need I guess we've got people online as well. How will I monitor the questions? You have that? Oh, okay. Okay, great. So I don't know if anyone has some questions. Yep, perfect.
Thank you, Andrew. Great work, obviously, and your all your efforts in using advances in machine learning to field like surgical education is very inspirational. My question is, what are your thoughts and I guess plans for taking all the great work that you've done and trying to scale this, either nationally or internationally? There's training programs everywhere, and I'm sure eventually they can take advantage of such great work that you've done to improve assessment, feedback, and so on. What are your thoughts about that?
Thanks, Amin. Well, I'm a big fan of your work, and we were talking last night. You're doing the legwork for me in some ways, right? So there's one thing to be able to do the work that we're doing, even if it's multi-institutional, even if it's well vetted, but these models are homegrown in some ways, right? They're not optimized for performance. They're not optimized for real-time feedback. I didn't share one of our projects, which was, from the time that a trainee does something in the lab to the time that we can plug the model into the video into the model, get a verdict, deliver it back. The best we could do, it would take about 10 minutes to do all of that. By then, if it was a real patient, the aorta would be, injured already, and the patient would be already, there'd be chest compressions and so forth. There's a lot of work on the industrializing of these models. And I mean, that's just one piece of it, right? A lot of our stuff, especially for high impact journals, they want to see that these models are vetted against publicly available data sets, that they, endure the test of time, all the different characteristics out there. We're really not there. We're really in that discovery phase, but increasingly so, we do feel that burden, and I'm sure you do too in your lab, that the models that we create, can't just be academic projects. If you really want to have impact, you really have to do that final mile. I always thought the final mile was optimizing the delivery of feedback here, but no, it's not. It's the deployment part, right? That's where you're going to get true impact. So, that's going to be the next decade of work, is figuring that piece out. I think that's going to be biggest challenge, honestly, or for not just for surgery applications of AI, but for radiology, for pathology, all of these areas, is the implementation. Finding these models, learning these models, that's going to be increasingly a skill set that a lot of institutions, fantastic places like here in Toronto, where you guys have tremendous AI expertise, that's only one piece of it, right? How do you implement and apply? That's going to be.
So speaking of AI, where this conference is actually hybrid. So we're actually interfacing with the computer, and I've received some human feedback. Please repeat the questions because the people online, we actually have 87 people online right now, can't hear. And probably important for us to be using the microphone. So maybe we'll go to Dr. Howard, and then I'll take a few questions online.
Thanks again. Excellent. I get the sense that we haven't heard the end of the story about assessing surgical gestures. I was interested in when you're scoring these gestures, how much of the variability of the gesture score or assessment is between surgeons? How much of the variability is between patients or or do you know that? And if you draw people's attention to how gestures are assessed, can you get better assessments, reasonable assessments, assessments that match those of the AI out of different humans in the room, like the person doing the surgery?
So I believe the question is about the variability of gestures within a surgeon and between surgeons. What we found was that surgeons have certain idiosyncrasies in their behavior, that, surgeons tend to like to do certain things over and over again, and it almost becomes a fingerprint of that surgeon. So in our early work doing the sequencing of the gestures, I think that was a problem, because the models, instead of recognizing good behavior, or let's say ideal behavior for a specific outcome, the models were not recognizing that, but rather they were recognizing that this is surgeon A. And we know from past examples that surgeon A does a pretty good job. So we're going to say that, this is another case where there's a good outcome. So in our early work, we were not sophisticated enough. Well, really the reality was we just didn't have enough data to control for the surgeon himself or herself. Our more subsequent work in the last, let's say, 6 to 12 months, we have been able to adjust or control for that fact. And we know that the model, despite taking out the identity of that surgeon, knowing that it's surgeon A, taking that out, that the model still can persevere. Between surgeons, there's a tremendous amount of variability in these gestures. Gestures are very unstructured data. And so there's a lot of noise in there. So that's part of the beauty of these models, is that it can parse through what is otherwise a tremendous amount of noise.
Cool. I'm just going to take a few questions online, and then we'll go back to the live audience. So one of the questions was, you think that this technology could or should be part of the continuing assessment / relicensure of surgeons?
That would be, for me, that would be a huge win. So I'll tell you, when we had our first project on the kinematics and so forth, I had a interview request from NBC News, nightly news. And, for a quick moment there, I thought I was going to have my minute of fame until the reporter told me that, the story was about what was data that's collected in the operating room that we can use to sue doctors and hold them accountable for poor action. And so still young, but at least mindful and smart enough to decline that particular interview. My motivation of the work that we're doing here is we want to level the playing field. We want to be able to provide feedback so that we know that surgeon outcomes are variable, and there's good and there's bad and there's somewhere in the middle. And I'd love for it to be so that we can level that playing field. And so that's my absolute motivation to the work that we do. And so if that answer, that's at the core of what we're trying to accomplish.
So, question from Dr. Stanley Hamstra, and Dr. Hamstra is one of our leaders in surgical education. And I guess this kind of relates to, how do you assess the ground truth, if you will, of what you're measuring? Can, for example, human raters be considered ground truth? And then from a kind of a different angle, how good actually are human raters to evaluate surgical performance?
So obviously humans have biases within ourselves. And no matter if it's, surgical gestures are probably the most objective measure. You are either making a cut or you're making a spread. And so those have been relatively stable between observers. For technical skills, there's a lot of variability in our human raters. If we can get 60% agreement, that's considered pretty darn good for assessments there. But to answer the question, I think for all the reasons there where their ground truth may be a little bit tricky, the patient-reported outcomes are the patient-reported outcomes. The patient's outcomes are those, and there is, that is the ground truth for us. And so for me, that That's why no matter what the metric is that we're collecting for the surgeon, everything gets tied to what happens ultimately.
That makes sense. So let's go back to our live audience. We got a question over there, and then we'll go to Dr. Alman.
Thank you, Dr. Hung. It's Ujin Choi, one of the PGY5 residents in general surgery. Thank you for a great talk. One of the biggest limitations, as you know, is overfitting of the models. I see you're trying to expand the number of centers and maybe increase the diversity of the data, but I want your insight how the future will look, how we mitigate the overfitting. And number two, you mentioned incorporating patient-reported outcomes and feedback. Have you considered mixed method studies? Because as so far everything is quantified, I believe it's hard to match that with human behavior at this point.
So
It's overfitting. Yeah.
First question was about overfitting. So overfitting for the group is when a model, if it's trained on data that's relatively limited, let's say data from just one hospital, it may perform very well for that hospital and only for the surgeons and patients from that hospital. But the moment you look at a different hospital, that model will just kind of fall apart because it's not seeing, everything in real life. Therefore, the necessity of, in our case, multi-institutional studies, we were talking to Dr. Alman yesterday that it is pretty much a requirement that any meaningful study validating these metrics have to be collaboratives, where you are looking at not even just a few hundred patients, but really in the thousands, right? And then that diversity geographically, social, economically, racially, all that sort of thing, it has to, be taken into account. From the quantifiable side of things, I think, ultimately, I think everything can be quantified, even some of the more challenging aspects of, let's say, human perception. That's probably the last piece that's going to be hard to quantify, but I think, those things can be done in a structured manner as well. But yeah, yes, the easy stuff that can be quantified, that's the low hanging fruit. And then as we progress and mature in our methods, we're going to look at, that human element. How do you quantify that piece of it? I think ultimately we will be able to do that.
Question from Dr. Alman.
Great. This is a fantastic talk. And Chris, I was struck by your slide you showed where you showed when people were looking at people evaluating people for suturing, and then where the AI program looked at it all over the place. And it reminded me of the study that was done on chest x-rays in AI, where they looked at chest x-rays, what disease it could predict, and it predicted diabetes. And then they looked at several populations and still did. It's been very hard for people to figure out why it is that chest x-rays predict diabetes better than any other kind of test we have. I'm just wondering whether or not, all the other data that comes out along the way, are there ways you can sort out why it's predictive? Because those could be really important things for how we can train people and how we can assess people in between. How do you pull them? I know the chest exercise has been really hard for them to figure it out. I think kind of some ideas, but I'm not sure if it's so rigorous.
So the question refers back to, Dr. Alman's question refers back to the slide about explainability, where the computer model was looking at a place where the human raters were not looking. Look, I think there's two aspects to machine learning. There's certainly the supervised portion where the models are simply learning what humans provide as labels. And I think that will extend, that merely enhances what, humans can do, in the sense that we just can't scale, for instance, and look at all the data points in great detail, but it's not a task that humans otherwise cannot do. But there may be something in those chest x-rays predicting diabetes that may be meaningful. And there may be something, in my slide where I was telling you, look at the crazy AI model looking in a space where there's no needle handling occurring. But could there be something going on during that time that was prep work for subsequent behavior that is still meaningful, right? So maybe to a human evaluator or even a surgeon looking at it, that we wouldn't immediately draw the connection and say that makes sense. But that's the unsupervised part of machine learning. And there's that promise that maybe it's thinking literally outside the box in a way that is impactful. And, as we gain, confidence in how we wield these sorts of capabilities, that maybe there is a day where we are making these discoveries that will help us. That's not tied to human biases, not tied to our own experiences, limited by our experiences, training, and so forth.
Well, there's been a tremendous amount of interest in your lecture for sure. So we have time for one more brief question and brief response.
Sure. Thank you, Dr. Hong. That was fantastic. A lot of your models seem to sort of top out in an area under the curve into the 80%, 85%. Is that kind of a natural limit of the analytics, or pushing that area under the curve higher? Does that require greater sample size? Where is the challenge that you're looking for to push those numbers? And I'm going to slide in one last question. That is, you've clearly had very extensive access to data from within the robot for the kinematics. Not all of the robotic companies are tremendously eager to share that data, and there's a lot of discussions over who has proprietary rights over that data. How have you managed those relationships? Apologies for the extra question, but I was interested.
Cool.
So I'll try to be brief. So first question, we top off somewhere in the 80s. I may be biased by my AI team, which is if it's in the 90s, it's too good to be true. If it's below the 80s, it's crap results. So 80s is kind of a sweet spot. The more serious answer is that we don't know how good is good enough, right? Because in our predictions, if the assessment is good enough in some ways to predict the outcome reliably, then that's good enough, right? It doesn't change maybe the end result piece. And so that's where we're at. But of course, if it's off by a little bit and it's the difference of let's say a surgeon in the future being credentialed or not, that's a big deal for that individual surgeon. So obviously we're always striving for the best outcome. What was the question is on proprietary data from different companies? Yeah. So there was an unspoken transition in my work from kinematics, which was very proprietary, right? One, company has that data, was willing to share it with us, but the models we were creating there were good for that one company and users of that one company's product. Whereas surgical videos is very democratic. Anybody with a digital recorder, even if you want to use a DVD, recorder, can record that data. And so that was a very intentional move on our part, because that's how we can collaborate very freely. Everybody has access to surgical video.
Well, we could probably continue on for another hour at least, but I think we need to draw the rounds to a close. Dr. Hung, thank you for a fantastic talk. Tremendous interest, and we're deeply appreciative. So for those online, we'll be closing this out. But for those who are here, if you have time and if you wish, Dr. Hung has graciously agreed to stick around for a while, and we'll be having a discussion informally in the rotunda, which is just by the elevators. I think we'll have some coffee, and so just please meet us here, and we'll just walk over. Thank you so much. That was amazing. That's really cool.